Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And today let's discuss how to create the desired size of capsulorhexis, what I feel is the best way to go about it, how to initiate the rhexis and how to measure the size of the rhexis which we need to create, especially in this era of premium IOLs. A rhexis of 5 to 5.5 mm is considered ideal and helps in the centration of the IOL and long-term stability of the IOL as well. So this is a routine case and I usually initiate the rhexis keeping in mind the Purkinje images, and I usually initiate with the help of this 26 gauge bent cystitome. Now this is my Utratas forceps wherein I have created a 2.5 and 5 mm of mark which helps me to judge the size of the rhexis. So now I have a mental image of the rhexis that I need to create, and I am aiming to create about a 5 mm of rhexis. So this is Haldipurkar's Utrata forceps, excellent forceps, gives excellent control, and that's it. We have a nice 5 to 5.25 mm of rhexis, just overlapping the 5 mm of mark. So now we have a nice rhexis, so I know that the IOL stability will be excellent. Now the nucleus rotates nicely, and now is the time to insert the probe of cataracts 3 phaco machine, bevel down. Some superficial cortex is removed. The bevel is then turned up. And we'll be doing a direct horizontal chop. This is the karate chopper. The nucleus is nudged a bit forwards with the chopper. The probe goes deep into the substance of the nucleus and we get a nice crack. This is around NS3, an ideal nucleus to learn direct chop. So now again we hold, and now we have 2 heminuclei. Now let's deal with 1 heminuclei, go deep into the substance of the nucleus, hold it nicely and then chop it. So now we have 2 quadrants, and now again we have 4 pie-shaped quadrants. Now shifting to the pulse mode, sub-chopping the quadrant and keeping in the central safe zone, and then emulsifying. So we have dealt with 1 quadrant, bringing the other quadrant in front of the phaco probe, giving some vacuum and trying to lift it up, and then bringing it into the central safe zone, and then staying at the plane of the iris and then emulsifying it. Now we are done with 1 heminucleus. Let's refill the chamber and coat the endothelium with OVD. And this is a nice practice to recoat the endothelium once 1 heminucleus is dealt with. Ensures safety of the endothelium, especially in hard greater cataracts. Now I have changed my chopper with a dialer, helps in better maneuverability. in the anterior chamber. So now sub-chopping the quadrants and slowly emulsifying them. And that's it. The last quadrant, the parameters are reduced. And slowly keeping in mind the posterior capsule, this last piece is emulsified. And that's it. With the help of the bimanual IA, the cortex is stripped off, brought to the center, safe zone, and then aspirated. The bimanual IA are excellent tool. They give you 360-degree access, great chamber stability. You can always switch hands to deal with the other half, and that's it. The bag is clear, and now let's inject the IOL. It's a hydrophobic IOL. The leading haptic goes in the bag. The trailing haptic is outside, so just nudge it inside. Push an OVD over the IOL. And the leading haptic is now resting over the anterior capsule. So now with the help of a dialer, just simply push it inside the bag. That's it. Now OVD is nicely washed both from above and behind the IOL for better outcome post-op. No IOP spikes and a happy patient. That's it. So you can see a nice cover of the optic 360 degrees with the anterior capsular rim, which will ensure an excellent IOL stability for the long term and a great outcome to the patient. Now the wounds are hydrated. So the take-home message is always attempt at least a 5.25 to 5.5 mm of rhexis in your initial days, and you will do great. I hope you like this video. Do like and subscribe to my YouTube channel. Thanks for watching.